Session. We start with the second part. We have Dr. Mudit Tyagi as the first speaker, speaking on infectious retinitis pattern identification. Yes. So Dr. Mudit Tyagi is from LV Prasad in Hyderabad, and he will be speaking on his experience with infectious,
Also, good morning once again, and first of all, let me thank AIOC and the scientific committee for having us as part of this session. So I'll be talking about common patterns of infective retinitis and how you can use these clinical clues to arrive at a diagnosis without resorting to too many lab investigations, and how we can train ourselves clinically to look at these diseases. Now, the first point, I know this may sound a bit rudimentary, but first thing that we have to do when we come into the habit of recognizing these patterns is to differentiate between the lesion. Are we dealing with a retinitis or a choroidal involvement? And while both of them can overlap, what we need to remember is that usually retinitis lesions are more superficial and they end up obscuring the vessel. So if you see a lesion which is slightly superficial and is obscuring the underlying blood vessel, then you're talking more in terms of a retinitis, whereas choroidal lesions obviously will tend to be slightly more deeper, and you can see a vessel coursing over the lesion. So these are lesions which are emanating from the choroid, will be lifting the things up, and you can see a vessel which will be passing over the lesion. So if you can identify the vessels coursing over the lesion, then it's predominantly a choroiditis lesion. Otherwise, if the lesion obscures the underlying blood vessel, then you're dealing with a predominantly retinitis lesion. So like if you see this, again you see a scar and you see a lesion over here which is obscuring the underlying vessels. So obviously a retinitis, whereas if you see this lesion over here, you can see a deeper lesion with vessels coursing over it. So that's a lesion which is emanating from the choroid and therefore a choroidal lesion. Now moving on to some of the common patterns of the diseases that we can see and how you can use these signs to identify clinical disease. So if you see a patient where you see this synechia over here, granulomatous capes, but more importantly, if you see the subvascular pigmentation, that in itself is a very significant clue to the possibility of TB being an underlying etiology. So a subvascular pigmentation along with vasculitis, think of TB as one of your differentials. A retinitis overlying a blood vessel, again a clue to a possible tubercular etiology. So if you see a retinitis overlying an underlying blood vessel, again that's a clue to the fact that you are dealing with a TB retinitis. Serpiginous-like choroiditis, a very common pattern which we have come to learn a lot about, and we will be talking about this in the subsequent slides, so I will skip upon that. But if you see lesions over here not involving the disc area and you can see pigment clumping over here, think of serpiginous-like choroiditis as one of your differentials, and again that points to an underlying TB as a cause. Moving on to some other common lesions, toxoplasma. Toxoplasma is one of the most common causes of unifocal retinitis. So if you see a unifocal retinitis, can happen in immunocompetent as well as immunocompromised hosts. No consistent direction of spread, can be occasionally associated with a very significant response. So if you see a very significant dense vitritis with an underlying single solitary lesion which you can appreciate through that vitritis, think of toxoplasma. Whereas if you see a significant vitritis but lesions confined to the periphery, that possibly can be a clue to an underlying acute retinal necrosis, and we'll come to that. So retinitis, and remember one of the other significant clues to identifying toxoplasma is the fact that a lot of times you will see it adjacent to a healed scar. So you see a scar and then you see a retinitis lesion adjacent to it, think of toxoplasma. So unifocal retinitis or lesions adjacent to a scar, like what you see over here. So you see this scar over here and then you see a retinitis lesion just adjacent to that. That's a clue to an ocular toxoplasmosis. One more important point to remember is the reactivation. So if you see a reactivation occurring from the center of a scar, that is a clue to tuberculosis. Whereas a reactivation occurring from the edge of a scar usually denotes a toxoplasma. So look at the pattern of reactivation. Moving on to viral retinitis. So CMV retinitis again usually ends up having a classic pattern which we can identify just by a clinical examination. You can see these areas of retinitis, arterial sheathing, multiple hemorrhages. You may have a granular appearance in the periphery. Think of CMV retinitis. The point to remember also is that patients with the CMV retinitis will usually have a very minimal anterior segment reaction, or the inflammation will be very less commensurate to the amount of the retinitis that you are seeing. And the reason for that is that most of these patients are immunosuppressed and therefore do not have the ability to mount a significant immune response. And therefore, while you may see extensive retinitis lesions, you may not see a significant AC or vitreous inflammation, which you may think should be there otherwise. So CMV retinitis has got its own patterns of appearance, dense retinitis with multiple hemorrhages. And another classic pattern can be what is described as a frosted branch angiitis. So absence or minimal vitritis, you can have a fulminant form over here. And remember, the loss of vision in fulminant form of CMV retinitis is usually because of macular involvement, whereas you may have a granular or indolent form, and these patients need to be followed up carefully because they are the ones who will end up having a peripheral necrosis, subsequent breaks, and are more at a risk of a subsequent rhegmatogenous retinal detachment that can happen. So perivascular form, or what is called a frosted branch angiitis, is something which we have already talked about. You see this extensive perivascular infiltration. And this is what you may see in a patient with a frosted branch angiitis. But what we also need to remember is that frosted branch angiitis, apart from HIV or seropositive patients, can also be idiopathic sometimes, can also be associated with Behçet's, sarcoidosis, lymphomas, leukemias, and occasionally SLE. Moving on to one more disease which we are seeing an increased resurgence and which is also very easy to identify if you get into the habit of appreciating these clinical clues, is ocular syphilis. So if you see a ground glass retinitis with a central clearing, think of syphilis. If you see these multiple small mealy lesions, again that's a clue to ocular syphilis. And what has been classically described as an acute syphilitic placoid chororetinitis. So you see a retinitis lesion at the posterior pole with more intense infiltration at the margins or at the edge of lesion. Think of ocular syphilis as one of your differentials. So if you do an OCT through that placoid chororetinitis lesion, what you will find is this RP nodularity, and that RP nodularity and photoreceptor damage again can be a classical clue to an underlying ocular syphilis. And if you do an OCT through these miliary lesions, you can see this full thickness retinitis. So miliary lesions with a full thickness retinitis, ground glass retinitis, placoid chororetinitis with RP nodularity, all of those are clues to the fact that you are possibly dealing with an ocular syphilis. And a point to remember is that ideally we should be getting a tryponymal test like TPH or FTABS done for these patients to identify them as compared to a VDRL. A lot of times we end up just getting a VDRL done and then we forget to look at TPHA. But the point is that tryponymal tests have got a sensitivity and specificity of more than 90% for syphilis as compared to non-tryponymal tests, which may only have a sensitivity of around 70 to 75%. So this is what I was talking about, the pattern recognition in ocular syphilis. A placoid chororetinitis with intense infiltration at the margins, ground glass retinitis with a central clearing, and these multiple miliary lesions. And another point to remember is that a lot of times these miliary lesions will appear in eyes which have been earlier erroneously treated only with systemic or local steroids. So if you treat an infective retinitis patient without the cover of an appropriate antimicrobial, that's inviting disaster. So if you have treated a patient only with steroids without an appropriate antimicrobial cover, which in this case for syphilis happens to be penicillin, then you may end up seeing these miliary lesions subsequently. So this is one more case which so classically highlights the importance of pattern recognition. So this was a patient seen elsewhere, thought of initially as intermediate uveitis, was given steroids, the patient did not respond. Subsequently started on immunosuppression, still the patient vision kept on going down. Finally, after even IVMP was given, and then at the last resort, the treating physicians gave the patient Ozurex, and you can see these two Ozurex implants. But then when the patient came to our clinic, what we saw along with these areas of hemorrhages were these multiple small miliary lesions. And the moment we saw them, we thought, are we dealing with syphilis? We got the patient tested for HIV as well as TPHA. The patient came positive for both. He was seropositive as well as positive for syphilis. This was a boy who happened to be a recreational drug abuser. But the point over here is that how classically can these clinical clues help us in identifying these diseases. So if you see this multiple miliary lesions, then think of ocular syphilis as one of the differentials. I'll just take one more minute if I can be allowed. Thank you so much. So acute retinal necrosis, another common clinical pattern. You see this extensive confluent peripheral retinitis. That is a clue to an acute retinal necrosis. In patients who are systemically severely immunosuppressed, if you see this mud crack sort of an appearance with retinitis and occasional perivascular sparing, that's a clue to a progressive outer retinal necrosis, which happens in significantly immunosuppressed individuals. Just one last point about endogenous endophthalmitis and how you can use that also as a clinical clue. So if you see a retinitis or lesion over here, and if you do an OCT, this was a very nice paper which showed how OCT can help us in identifying the underlying etiology. So you see a lesion emanating over here from the subretinal area, protruding into the vitreous with this classic sun cloud sort of a sign described in OCT. That is a clue to a candidal involvement. Aspergillosis, on the other hand, tends to be more diffuse and more subretinal. So I will sum it up now and remove the rest of the slides, but these are the main points, and the main thing to remember is that a lot of these infective retinitis can be identified just on the basis of important clinical clues, and you do not may possibly need to resort to too many lab investigations. All we need to do is keep our minds open, do a good meticulous indirect and a retinal evaluation in most of these cases. Thank you so much.
So, thanks,
Next, I invite the next speaker, Dr. Malika Goyal. She's retina and uveitis consultant at Apollo Hospital, Hyderabad. She'll be talking to us on retinitis and HIV patient step-by-step management. She has vast experience in handling HIV patients. Over to you, ma'am.
Thank you very much. So, retinitis only. I'm not going to speak about choroiditis and granulomas. In HIV, immune compromise leads to opportunistic infections, which are usually a manifestation of disseminated disease elsewhere in the body. And antiretroviral therapy often unmasks these infections by causing inflammation in a previously quiet asymptomatic eye. Most common is HIV microvasculopathy, seen usually with low CD4 counts, does not have any visual significance. The infection most common is CMV retinitis with low CD4 counts, has a cottage cheese and ketchup appearance because of the granular necrosis with hemorrhages. The importance is that it identifies that this patient is an AIDS patient, not only HIV infected, but AIDS, and the need to start ART, or if they are already on ART, that has to be improved. Vision loss is common due to extensive retinal necrosis, optic atrophy, macular scarring, and retinal detachment. It could be very mild, occasional patches which can be missed. It can be neuroretinitis, retinal vasculitis, or in relatively less compromised patients, it can be just iritis. And these patients, you can suspect that this is CMV anterior uveitis and be on the lookout for retinitis. Some of them have severe vitreitis where you cannot see the retinitis but have to have clinical judgment. Very often in viral retinitis, we see proliferative retinopathy because of extensive vasculitis causing ischemia. So they present with NVD, NV, vitreous hemorrhage, neovascular glaucoma. So apart from treating the retinitis, we also have to take care of anti-VEGFs, laser, and vitrectomy if needed. Treatment of CMV retinitis is intravitreal ganciclovir for immediate action, and then maintenance with oral valganciclovir. In resistant cases, foscarnet or cidofovir. But ultimately, these will only for 2-3 months or 6 months, but the long-term resolution will depend on improving the immune status with ART. Intravitreal ganciclovir is obviously more effective, and the newer dose recommended is 5 to 6 milligrams once a week. Earlier we used to give 2 milligram twice a week, but now I have shifted completely to 5 milligram once a week. Works very well, reduces the number of injections. Now this is to show that a patient on oral Valgan does not improve macular threatening retinitis, but as soon as you give intravitreal, within 5 days it's very good. Similarly, if with retinal detachment, there's an urgent surgery indicated. You need to get it urgently under control. So intravitreal injections and immediate surgery is possible within 5 days. Resolved retinitis, reactivation very often happens when the immune status drops again. And it happens at the edges of the resolved retinitis. And even after the retinitis is resolved, they need monitoring because the atrophic retina can develop breaks or large areas of retinal loss leading to detachment. Peripheral detachments can be managed with laser demarcation. But when they have to be operated, plan long-term oil tamponade, for which you need to remove the lens because it will form cataract, and have a higher viscosity oil for lower emulsification. And remove oil only when there is a CD4 counts have improved, there is a less chance of recurrent CMV infection. This is how it often looks like a sieve, where large multiple breaks. The entire area can be treated like one large break and lasered with one demarcation row. And they can tolerate oil very well for several years, most of them. Immune recovery happens in these patients even after surgery. They develop cystoid macular edema because of ART, and steroids can be given if the physician approves the immune status. Acute retinal necrosis, Dr. Modityagi has already described, so I will not talk much about it. Only to say the etiology is mostly herpes viruses, but the triad, classical triad, talking of peripheral vasculitis, peripheral retinitis, vitritis, can completely misguide us into ignoring the disease, possibility of disease when we see scleritis, severe pain, iritis, and it completely masks the posterior disease. And sometimes the retinitis is primarily posterior pole, and again that's still ARN. So it's important to remember these points. Very often these patients can develop retinal detachment and require surgery. Treatment is intravenous acyclovir or oral val acyclovir. Steroids in HIV patients have to be based on physician approval, and intravitreal ganciclovir also works very well. Again, PON described already by Dr. Mudit, so I will not talk much about it. It's a blinding disease, very rapidly progressive, seen usually in very low CD4 counts, highly immunosuppressed patients. And caused by herpes group of viruses. Pneumocystis carinii is usually picked up on routine screening, causes these coin-shaped subretinal lesions. They do not have any visual significance, but alert us to the possibility of pneumonia, which requires pentamidine therapy. Toxoplasmosis in AIDS is slightly different from regular toxoplasma. They have larger lesions, may be more difficult to distinguish from other infections because it's atypical, and can be bilateral, multifocal, with recurrences as soon as we stop treatment, and can be often associated with CNS involvement. We can also see retinal abscesses as bilateral, extensive, rapidly progressing to panophthalmitis as part of endogenous endophthalmitis. And often we can see two different problems in the two eyes of a patient, CMV retinitis in one, endogenous endoph in the other, or immunosuppression-related malignancy in the other eye with CMV in the one eye. And lastly, masquerade in immunocompromised patients. These can be very young patients presenting with bilateral intermediate uveitis, subretinal deposits, retinal vasculitis, not responding to steroids. So suspect in any non-responding intermediate uveitis. And if it's an immunocompromised patient, CNS involvement is common with poor prognosis. Thank you.
Thank you, ma'am, for the nice talk. Next, we'll move on to the next presentation on post-fever retinitis, the many phases, by Dr. Ankush Kavali. He is a senior uveitis consultant from Narayana Nethralaya, Bangalore. Over to Dr. Ankush.
Yeah, thank you. So I'll be mainly discussing the presentation, the various clinical signs, and the various etiologies. So the term post-fever retinitis or epidemic retinitis is an umbrella term which describes this peculiar retinitis entity which has been associated with various etiologies like chikungunya, dengue, West Nile virus, rickettsia, and even typhoid. Patient generally give a history of definitive fever 2 weeks to 4 weeks ago. They can come with this kind of skin rash and many times joint pain as well. The lesions of retinitis in this entity, they are mainly located at the posterior pole. They can be around the disc like this. They are mainly cortical spot-like retinitis lesions. They can be along the arcades. Retinitis lesions can be associated with severe macular edema, and when they start resolving, one can see this kind of macular star or macular fan formation. Lesions can be focal or multifocal. We have recently described this ring retinitis, which can occur in mid-periphery in almost 10% of patients in this particular study. This is a case which was treated only with steroid without any antibiotics, and we noted the migration of this retinitis lesion towards the macula. when the retinitis starts resolving, this kind of subretinal yellow dots can be seen, subretinal precipitates. They can be numerous and can be confusing with the syphilis as described by Dr. Mudit, or a lymphoma as well. And this is OCT scan which shows the exact location. OCT is more important. You can see the inner retinal hyperreflectivity with backshadowing and subretinal fluid, outer retinal edema, but you never see necrosis on the OCT scan in this particular entity. When it resolves, one can see hard exudates in the layer of Henle. Many times subretinal exudates can be seen. And this is again a rare occurrence of subretinal fluid in this entity. This sign we have recently seen. This patient just presented 2 months back, and at this area the patient had retinitis lesion, and when it resolved, the appearance like this crumple shaped of retina, if you can see here. And when we did the OCT scan, we discovered this newer sign which has not been noted earlier. But this particular sign has been described as a vertical hyperreflective lesions in a patient of lymphoma. Well, this patient is still under follow-up. We'll know how the lesions behave over a period of time. Coming to FFA, the vasculitic leakage or staining can be seen at the site of the retinitis lesions. And many times you detect NVE, even in absence of significant CNP areas. CNVM, I have not seen myself, but there are reports as well as this patient from my colleague, which was treated with anti-VEGF and it resolved. Coming to anterior segment, yes, we do see anterior segment reaction, but never hypopyon. Out of 350 cases what we have, these are the only 2 cases which had trace hypopyon. Now coming to etiology, we have many phases for etiology as well. This is the first series which we published of 10 patients presumed to be rickettsial retinitis because the diagnosis was based on Weil-Felix test. But subsequently there was another series from Arvind Coimbatore in which they have done the not only Weil-Felix test but also ELISA for rickettsia conurei. And as you can see here, the last 4 patients which are tested negative for Weil-Felix, but they were positive for ELISA. So this means that negative Weil-Felix test does not rule out rickettsial etiology. So next was our largest series of epidemic retinitis in which we noted that most of our patients tested positive for Weil-Felix test, followed by IgG dengue and followed by chikungunya. We also noted in this series that many patients, they had multiple positive investigation, like patient tested positive for Weil-Felix as well as for Vidal. Some patients were positive for chikungunya IgM as well as showed very high titers of dengue. And then there was this major article which has proven the etiology with using the gold standard investigation, the etiology of West Nile virus. But subsequently, we didn't see any reports on this. Similarly, there are a small series of chikungunya and dengue as well. Few authors tried to hunt down the organism by using even next generation sequencing. So they have isolated multiple organisms, but none which can explain the occurrence of fever or skin rash or joint pain. So we'll try to look at the other side of the coin by studying the seasonal variation of this disease. And we use this integrated disease surveillance program. And noted that we compared the graph of epidemic retinitis with the graph of other outbreaks which occurs in the community. To our surprise, not a single graph was coinciding with this particular entity. But again, this IDSP registry did not include the outbreaks of rickettsia and West Nile virus. The study was done in 2015. So recently, I noted that they have started including rickettsial disease. During pandemic, various authors correlated this entity with the COVID-19. But when we studied the epidemiology as well as the seasonal variation, the study did not support the etiology of COVID with this particular entity. To our surprise, there was a report from Bangalore itself when the authors studied the seasonal variation of rickettsial fever in children, and the graph correlated with our graph of epidemic retinitis, suggesting the possibility of rickettsial disease as an etiological agent for the epidemic retinitis. We have various phases for treatment as well. We try to compare various treatment modalities, and we try to compare in our various publications the rate of resolution for macular edema and retinitis, and we noted no big difference as far as the resolution rate is concerned, whether you treat this patient with steroid or without steroid, treat with anti-VEGF or without anti-VEGF. But I can say one thing, that the patients resolve very well even if you treat them only with doxycycline, with topical steroid or even NSAIDs. One more hidden phase of this entity is visual fields. So even after a complete resolution of retinitis, one can see this kind of scotomas, which can persist for long. So this, in this particular case, it was more than 6 months. But I have cases in which the scotomas were permanent, even after resolution of the retinitis lesion. So my 5 take-home points. Once you see the patient who has been diagnosed by physician as a dengue, typhoid, or some viral fever, the patient gives history of skin rash or joint pain, the patient comes to with focal or multifocal, but non-necrotizing retinitis, with or without macular edema, formation of macular star, do suspect epidemic retinitis. If you do the OCT scan, it will show inner retinal hyperreflectivity, ONL edema, mild NSD, but no necrosis. Do the baseline blood workup. If you are interested in knowing the etiology, do Wileflex test, typhoid, viral, chikungunya serology, or dengue serology. But if you notice the dramatic response to the doxycycline, even with or without steroid, that may prove the diagnosis of epidemic retinitis. Thank you.
Thank you so much, Ankush. And may I now invite our next speaker, Dr. Rima Bansal. Dr. Rima Bansal is a consultant in retina and uvea service at PGI Chandigarh, and a distinguished speaker with a huge amount or volume of work in infectious choroiditis. So thank you for joining us, ma'am.
A very good morning, all of you, and thank you, Mudit, Padma, Malika, and Ankush, and thank you, AIOS and Scientific Committee, for having me in the subspecialty course. So the topic given to me is infectious choroiditis, serpiginous and beyond. And if you carefully see, I'm sandwiched between known speakers on retinitis, and the next speaker is going to be talking on pattern recognition of choroiditis. So for me, it was difficult to know what exactly I'm expected to speak on. So I thought of putting up, my material on what I believe would not be covered in the subsequent talks in this subspecialty session, and something that I'm sure all of you are not aware of. So when you talk of, choroiditis, involvement of the choroid, it could be choroiditis or it could be chorioretinitis. Now, from what you've seen in the previous talks, most of the retinitis may or may not be associated with choroid involvement, and hence the term is like overlapping between chorioretinitis or retinochoroiditis. So for that, I thought I'll just stick to choroiditis in these few minutes. So when we talk of serpiginous, the word that the etiology that comes to mind of all of us is, of course, tuberculosis. So the moment you talk of serpiginous choroiditis, you think of talking of TB, because here we're talking of infectious. Had it been non-infectious, we could go on for autoimmune causes of serpiginous. So here we're not talking of that. So I thought I'll take you to various etiologies that have been reported in serpiginous choroiditis when it comes to infectious agents. So first, we all know about the TB being the serpiginous-like choroiditis among the serpiginous choroiditis with TB as the etiology. So there are a couple of case reports highlighting the involvement of SARS-CoV-2, herpes virus causing serpiginous choroiditis, toxoplasma, fungal, and others. So TB, we all know, this term was coined in 2003 by Dr. Vishali and Dr. Amod Gupta, and where the involvement of serpiginous choroiditis due to TB was termed as serpiginous-like choroiditis. The importance of this term is that it has a very typical phenotype. It has a very good response to the antitubercular therapy, and the recognition is almost instant when you see these patients in your clinic. So these lesions are typically multifocal. They have a serpiginoid extension. And we also know that many of you and many of us who have seen this etiology have recognized MTB from the eyes of these patients. This is the classical presentation of these tubercular serpaginoid choroiditis. It's a very classical phenotype. The autofluorescence is very classical, and this is how it heals clinically as well as an autofluorescence. We also know that some of these lesions have a tendency to come back, maybe in the form of a paradoxical worsening or in the form of a recurrence. So paradoxical worsening is, we are all very aware of it. It happens. It's a well-known entity. And you may have positive Montaux, you may have involvement on the radiological imaging, but even if you don't have these positive radiological imaging, you have the clinical phenotype in front of you in an endemic setting. I think the diagnosis is not really difficult. And this is how it heals, with exuberant pigmentation all around the fundus, with the classical foveal sparing. Even if this kind of pigmentation is there, we have these patients spared with 6/6 or 6/9 vision. Now, the problem comes when we don't have TB as the underlying etiology, and many of us would not even know that there are reports of the herpes virus causing similar type of presentation. So this was a publication on 9 patients with serpiginous choroiditis, where they did PCR from the aqueous tap of these patients with active disease, and they found five were positive for VZV, 1 for HSV, and 3 were negative. So this is, if you look at the clinical presentation, very similar to the tuberculoid. So you have this serpiginous choroiditis here, but the etiology is viral and not TB. So we need to keep this in mind from this publication. And another case report of a viral etiology of causing serpiginous choroiditis, where this was a 57-year-old black woman who had, because the authors felt there is a link of viral etiology with this entity, and this is what they found, a typical brush fire appearance of the serpiginous choroiditis, and this was also complicated by a choroidal neovascular membrane. So a complication like CNVM is well known in serpiginous choroiditis. So here again, a herpetic or a viral etiology was the cause of serpiginous choroiditis. With the COVID, this entity again got a new etiology with the SARS-CoV-2, and this was the first report of this virus being the etiology of serpiginous choroiditis. Whether it's an infective trigger or an immunological trigger still remains a question to explore, and this is how they found that this infection, the patient became symptomatic just 1 month after the COVID infection. So this is the classical presentation of this patient that they reported. You can see the active lesions on clinical appearance, how they are seen active on autofluorescence, and of course confirmed on the angiography. Toxo, we have the report from Dr. Padma Malini's group, not very well known, but I think we all should be aware of this possibility as the cause of serpiginous choroiditis. So this was the classical presentation. You can see the lesions in the posterior pole, in the mid-periphery, and even in the inferior periphery, where you can see active lesion. The fluorescein confirmed the window defects and the active lesions. So this was basically a 32-year-old. Again, the background sometimes is similar between TB and non-TB etiologies. You have a 32-year-old male where the serology from the blood was positive for toxo, and the PCR confirmed the toxo from the aqueous humor. Now, when you talk of infectious non-tubercular serpiginous choroiditis, I found these 2 reports in JAMA, where the 2 very rare causes were explored and reported by the authors. Now, this was the first case where the patient had hunting as a hobby, and after testing these patients for the known causes for general for TB and syphilis and all that, they tested the patient serologically for Francisella tularensis, and they found that this serological testing was positive. So the authors attributed, now if you look at why I've put up these pictures is, if you look at the clinical presentation, the phenotype is quite similar to what we talk of serpiginous-like choroiditis. So here they found this serological testing positive, and this was again a rare cause of serpiginous choroiditis. The patient was treated with ciprofloxacin and responded well. The second case, again, if you look at the clinical presentation, the right eye has serpiginous choroiditis lesions in the posterior pole, very well seen on autofluorescence and fluorescein angiography. This patient had Montaux 18 millimeters. So to begin with, the diagnosis was tubercular serpiginous choroiditis. The patient received ATT, but after 3 months, there was a new lesion in the left eye where you can see in D, E, and F. So they tested the patient again. The serology for Bartonella Hensley was positive. The patient received moxifloxacin and then responded well to this. So these were 2 case reports of very rare infections as the cause for serpiginous choroiditis. And again, there is a series where they have pointed out fungal etiology from patients of serpiginous choroiditis and patients of azure. Now, the important is that the authors, they haven't given the reason for why they suspected fungal, but they tested serology and they tested the PCRs from the blood samples, and they found positive reports of various species of Candida from the blood of these patients. So what they did was they tested the serum or the whole peripheral blood. They checked for the fungal growth in the appropriate media. They also tested the antibodies, again different Candida species, by immunofluorescence. They tested the fungal genomes by quantitative PCR, and antigens from Candida famita and other yeasts were tested by the slot blot assays. So to summarize, when we talk of infectious serpiginous choroiditis, of course we have tubercle etiology as the first possibility and the first thought. But from these anecdotal case reports, we do have to keep things in mind. But of course, after ruling out the most common, depending upon the clinical setting, depending upon the population, depending upon the patient, from which geographical the region the patient comes from, and if there is no definitive evidence, it needs a very careful interpretation. So thank you very much. And with this, I invite you all to the Silver Jubilee of USI 25th Annual Meeting at Chandigarh in October. Thank you very much.
Thank you very much, Dr. Bansal. Thanks a lot. I think we'll start our panel discussion quickly. We have just 5 minutes. The first question I'd like to have for Dr. Bansal is, when you see a patient with serpiginous or serpiginous-like choroiditis, and you do the investigations for tuberculosis, etc., would you advise starting immediately on steroids if the disease is active without ATT cover, anti-TB therapy, or what's your protocol, just basically for everybody?
So, if the disease is very active, threatening fovea or involving fovea, we do a quick testing for Montux and CT chest. Usually the reports are available within 2 days. And if it's really threatening, it's a good idea to start steroids to this patient.
And if your investigations are negative, would you then not start anti-tuber, or would you still start?
So the steroids would be given, but the anti-TB therapy would depend upon any of the positive investigations for TB. Any evidence of.
If they are negative, you would not give anti-TB. You would just increase the immunosuppression if needed.
Yeah. So if we have no evidence of TB, no latent TB like Montux or even IGRA is negative, there's no radiological sign, we do start with steroids, but we keep the possibility of ATT. We discuss with the patient that usually we do give, but in this case, since we don't have any evidence, we would treat with steroids. And in case the patient has a recurrence or a paradoxical worsening or something, then we would keep an option for ATT. But that would be empirical, telling the patient that he doesn't have any evidence, but we may have to treat if there is a recurrence.
Thank you.
I have one more question. So what you will do if the patient is positive for immunological test for tuberculosis and you isolate the organism, say HSV, from the antechamber tab?
No, we don't do that.
Because I'm asking because I have such, one patient in which the MONTU is positive, quantiferon is above 10, and the HSV has come positive from the antechamber tab.
So in that, so you are sending your aqueous tab for, all PCRs, right? Multiplex PCRs.
He also had a deep stromal keratitis for which the AC tab was done and which has come positive for HSV.
So here, I think then looking at the clinical scenario, there is corneal involvement. The PCR is positive. I would give more importance to that rather than a Montux of 10. Right, so if you have an anterior segment involvement with keratitis, with serpiginous, with PCR viral positive, I'll give more weightage to the viral etiology.
Even if the keratitis is not active, it is a deep stromal keratitis which is
So the patient has had, the keratitis in the past. So I would still go for that, telling the patient that, of course, we discussed with the patient that the commonest etiology, we are not able to catch it by the investigations. So giving an antiviral, I think, is no harm. Steroids under the cover of antiviral. But this is a very, very rare situation.
Yeah, I have a question for Dr. Modi. He nicely illustrated the various patterns of infective retinitis, but there are non-infectious retinitis also can cause. How do you differentiate infectious from non-infectious retinitis?
All right, so the first thing is the ideal dictum usually is that all retinitis are infective unless proven otherwise. So first you start with the presumption that you are dealing with, rule out all the infections, and like I said, most of these infective retinitis do have a pattern. The common non-infectious retinitis that you can encounter predominantly will be Behçet's. That is the one which will be most common. And most of the times with a careful history and evaluation, you will be able to identify that also. Apart from that, if you see a retinitis which is fleeting, in the sense you see a retinitis over here, regresses, goes away, then you see appearance of new lesions elsewhere, those history of genital ulceration, HLA-B51. So those are clinical points which you can later on combine and then rule out. But most retinitis otherwise are infective. Once you have ruled them out, then you can start exploring non-infective causes also, but the most common one usually what we encounter is Behçet's, and again that can be identified on the basis of its clinical appearance.
Thanks. A last comment I wanted to make was when we talk of frosted branch angiitis or miliary lesions, these are only morphological features. These are not etiological features. So we should not get fixed on that. If you see this is the diagnosis. Yeah. So because while miliary lesions are seen with TB, with syphilis or lymphoma, I have also seen with TB where it resolves completely with ATT. Same for frosted branch angiitis. It can be a host of things.
So the point is all of these patterns are a clue to what can be the higher etiological possibilities. So if you see a lesions like that, think of these are the possible diagnoses, then you can tailor investigations accordingly.
And clinical judgment remains supreme. I think investigations can be false positive, false negative. It's ultimately clinical judgment.
Yeah, there are no questions. We would like to thank all the speakers, co-chairperson, and the moderators for audience participation. Thank you.
So can we invite the chairpersons and the moderators for the next session, please?